Good morning. I'm Dr. Sharath Reddy, interventional cardiologist from Medicore Hospitals, Hyderabad. So I'm presenting on role of IVUS in treating CTO lesions. Thanks for K-Imaging for giving me an opportunity to present. IVUS is very important tool in CTO interventions to enter ambiguous entry, to re-enter true lumen in antegrade wiring, and enter antegrade space with the retrograde wire in difficult reverse cart cases, and to identify and navigate side branches within CTO segment, to evaluate lesions distal to CTO, and to choose landing zones and shunt diameters and length, and also to do PCI with low contrast. To enter ambiguous entry, in cases like this, osteal chronic total occlusion, that's a ambiguous cap. In such situations, IVUS plays very crucial role in completing CTO PCI. You can see in this case, there is a good retrograde collateral filling LAD. Yeah, so what happens, if you don't use IVUS for such cases while doing antegrade wiring? So we can see here, if you don't use IVUS and you do an antegrade wiring, if the wire goes sub-intimally into the proximal LID and you dilate with the balloon, then you end up in occluding the left circumflex or the bifurcation branch, if it is the other bifurcation. And if you do retrograde without antegrade preparation in such patients, and if your retrograde wire comes and enters your LMCA again subintimally, and if you dilate that area, you may end up in occluding LCX. So in either case, so your antegrade preparation is very, very important, for which IVUS plays a very great role. So you can see here, with an IVUS, you can choose your proximal entry zone properly. And once you enter proximal cap, then you can come retrograde, or you can even complete antegrade if it goes true to true. If it doesn't go true to true, then you can do a reverse cart in the proximal LID, and you can take your wire out, retrograde wire out, that is externalization, and followed by completion of procedure. So you won't end up in occluding your side branch, that is LCX, if it is an LMCA bifurcation. So what we have done here is it's a fine cross with wire and optic cross. So it's a live IVUS guided entry, and then we went retrograde as it went through to false lumen, and we created a space over antegrade wire in the proximal LID, and then we have sent our retrograde wire under IVUS guidance into the guide. So, and subsequently, we completed procedure. So for this technique, you need a 7 French guide with an optic cross and fine cross microcatheter. So you can see here, this is, post procedure. Yeah. So in cases like this, again, oscillatory total occlusion with the bifurcations within the CTO segment. So we can also use a slipstream technique, so which takes a 8 French guide, you can see here. So 8 French guide over which optic cross microcatheter is placed. And on the same wire, we can place a crusade catheter. You can see here. So this is optic cross here, and this is a crusade catheter on the same wire. And then we are trying to enter into the LAD. So these are the sections at various levels with IVUS to identify side branch. You can see here, this is the side branch here. And immediately after side branch joining, you can see size enhancement of the vessel. So what we have done through the crusade, and we have sent, initially conquest wire, I think Harnett wire, and followed by, we downgraded it to Gaia 2. So you can see this is the Harnett wire. So And we can see here, so the Harnett wire is just entering the proximal cap at a right point. You can see here. So this is the proximal cap, and we entered through the cap. Okay, and once Harnett is entered, we have to remove IVUS catheter without disturbing our antegrade wire. So that's very, very important. So what you can do is you can, yeah. So what you can do is you just pull the wire back. Since IVUS is a opticross is a monorail, very short monorail catheter. So once you pull wire back, the opticross is out of your wire, and then you can remove opticross out of vessel, and then you can do a balloon trapping and removal of this crusade catheter, followed by advancing a microcatheter, and you can complete your rest of the procedure. Coming to the difficult reverse card situations and difficult externalization situations, you can see this is an RCS CTO in a post-CABG patient who had good collateral from LAD, good septal collateral, so which we can appreciate here. So we tried antegrade wire escalation but failed as the wire went into subintimal plane due to understandable reason, that's a loopy proximal RCA. And we tried retrograde, but wire didn't cross lesion. We were stuck there. So, and then we went ahead with, director reverse cut, but balloon couldn't go into the lesion. That's when, we decided to go ahead with conventional reverse cut and also extended reverse cut within the normal segment. So we did that. We can observe, the wire just slips into the true lumen. But subsequently, we failed to externalize this wire into the antegrade guide catheter. So then we did an IVUS, you can see here, as in this case. So IVUS was subintimal here. Yes, it's subintimal. You can see this is a wire. And here the wire is intimal. So here it's subintimal, and here the wire is intimal. You can see here, it came into lumen. And as we come proximally, this wire, which is in the lumen, again goes back to subintimal. We can observe here. So this is the wire. It goes back to subintimal. So that's what happened. You can see here. Yeah, now it's gone back to subintima. So this is in the proximal RCA. So that is the reason why couldn't be externalized into the guide catheter. So this is what exactly happened. So wire came into true lumen, and again here it went into subintimal plane because of the tortuosity in the proximal RCA. So the solution here is you just send a guideliner to point B where it is in true lumen and then externalize. So that's what we did. We have advanced guideliner to the point B where the wire is in true lumen, and now you can see the wire came back into the guideliner and guide, and we externalized and we completed procedure. Yeah. So in difficult reverse card cases, so what we have to do is overlap both antegrade and retrograde wires by at least 20 to 25 millimeters. And this is one place where forward-looking IVUS catheter helps better in understanding the strategy. So once you create space over antegrade wire and advance IVUS catheter, so these are the possible anatomies which you may come across. One, both wires might be intimal, and both wires can be subintimal. So you can see this is with IVUS. This indicates antegrade wire. So when both are intimal or subintimal, so take a balloon size which is equivalent to vessel. And then you can take a retrograde wire of Scion or Fielder FC, because you don't need a penetration wire in this situation. If this doesn't work, then you can go for a guideline assisted reverse cut. If that also doesn't work, then you can even do a stunt assisted reverse cut. And if antegrade wire is intimal and retrograde wire is sub-intimal, in this situation, again, take a balloon size, maximum size possible with IVUS, and you have to take a very penetrating wire, retrogradely, because it has to penetrate across intima and come to true lumen. Either take a conquest or harnett wire, and if that doesn't work, move the base of operations based on IVUS, and also you can use IVUS guided retrograde wiring. And if antegrade wire is in subintima and retrograde wire is in intima, so you can take a biggest size balloon followed by a retrograde wire, highly penetrating wire, either harnett or conquest. If that doesn't work, then we can adapt to IVUS guided retrograde wiring. And we can also use retrograde knuckle uh, to enter subintima with a retrograde wire. So after that, we can apply again this there. So yeah, in cases where after opening CTO, you're not able to see side branches or not able to identify main branch. So like this. So this is an LED CTO where we entered, I was guided. You can see the wire entry is quite good. So this is a media and wire is almost at the center of the vessel, and we dilated, we realized, the wire is in a vessel, but we were not sure, whether it is diagonal or LID. So then when we did an IVUS from that branch, so we realized, we can see at 3 o'clock, there is a big vessel, which is coming up. You can see, yeah, this is the vessel. So this is actually LED. We were in side branch. So then we located this LED joining point into the main vessel. So this is the point where LED was joining. You can see here, this is LED. And we understood the relation between, IVUS catheter and the wire. And we took a view which is perpendicular to uh, this, and then we advanced a wire. This is a filter XTR with a over through a crusade catheter. You can see, the wire is entering distal LID, and then we completed procedure into LID. So, and to evaluate lesions distal to CTO, so you can see in this LID, proximal LID CTO, so with a good retrograde collaterals from right coronary artery, and which is filling quite nicely, retrogradely. But you can see a pattern, in a retrograde filling, these septals are filling this part of LID, and distal septals are filling this part of LID, and this part is actually not visible even in dual injection. So after opening this CTO, you can see in the exact site, where uh, the vessel was not visible in a dual injection. So there is a kind of lesion, which appeared. And when we did an IVUS, you can see this is the IVUS. Distally, this is the vessel distally, so which is, bigger than at the site of, lesion appearing in fluoroscopy. So here the vessel is actually smaller and there is no block at all. So this says it is a negatively remodeled vessel, and there is no point in stunting such vessels. In fact, this is negatively remodeled because it is located at a watershed zone. So the segment above this zone is filling from this septals, and the segment below this zone is filling from this septals, and this acts as a watershed zone where the vessel can negatively remodeled and appears as a lesion on fluoroscopy, but when you do IVUS you realize it's only negative remodeling but no block. So we can avoid stunting these kind of uh, lesions which appears on fluoroscopy in post-CTO segment. And to choose landing zones in such cases where this is an hostile RCS CTO, you can see filling retrogradely from LID. And after retrograde wiring, once we opened vessel, we realized the entire RCA is looking diffusely diseased. But when we did an IVUS, so we made out plaque only in the proximal RCA, and the rest of the vessel, there is not much of plaque. So we stunted based on the plaque distribution in IVUS. So that is only the proximal segment. And when we repeated angiogram after 3 months, you can see here how the vessel is looking, distally. It's a nice vessel and there is no lesion at all. And you can see this is again immediately post PCI, and this is after 3 months. The vessel is nice, distally. So we can choose stunt length based on IVUS in such cases. And when you go with the subintimal tracking in CTO, like in this case, RCS CTO, the heavily calcified lesion, so where both antegrade wiring and retrograde wiring failed because of the calcium, we opted antegrade subintimal tracking. So in a subintimal tracking, we created a subintimal space. You can see here. So there is a huge subintimal space is created. My retrograde corsair is in true lumen. And yeah, so you can see here, the subintimal space is expanded, and wire is freely moving, antegrade wire is freely moving in the subintimal space. So in such scenarios, we can't inject antegradally. If you inject antegradally, your subintimal space will expand, and we can't complete procedure. In such cases, IVUS is the only way we can complete procedure. So we did a reverse cut and externalized wire, and I'm doing IVUS on externalized wire. You can see here, so there is a huge subintimal hematoma in the vessel. You can see true lumen is completely compressed. This is all subintimal hematoma. So what we have done here is we marked with IVUS where the subintimal hematoma is ending. Based on that, we did stunting, without injecting any contrast. So, and you can see, this is in the beginning how the vessel was, and this is the end of the procedure. Yeah. So in patients with renal failure like this, a case of right coronary artery chronic total occlusion with an EGFR of 50, sorry, it's a creatinine of 3.8, EGFR of 15 ml. It's not 50, so 15 ml. So RCS CTO, and you can see the left system is quite good. There is only mild disease. So in such cases, when there is a good sapid collateral, just go retrograde first, put a retrograde Y and use this retrograde wire as a marker for your antegrade wiring, that is antegrade wire escalation. That's what we did. And you can loop your retrograde wire for antegrade wire escalation and antegrade wire position understanding. So that's what we did here. And subsequently, once we cross lesion, entire decisions are taken based on IVUS. This is the first IVUS after opening CTO. You can see this is the CTO segment. And in IVUS, what we made out, this distal vessel is perfect. And there is a block here. And this is all CTO segment. So at this region, at this block, when we measured the block areas, it was almost 62%. So we decided to include it into stunting. And we have chosen B3 as a distal reference. You can see here the block area is less than 40%. And B6 was chosen as a proximal reference, where the block area is again around less than 50%. It's around 40%. So, and we took a stunt, and it's a 46 millimeter. So we deployed a 48 millimeter stunt, and this is post stunting. You can see we achieved good areas, 8.3, 7.1, 7.6. You can see the stunt is uniformly expanded. So to conclude, IVUS is very important in wiring of chronic total occlusions, mainly to enter ambiguous entry and re-enter true lumen in antegrade subintimal wiring, and IVUS guided reverse cut in difficult cases. And IVUS is important to identify and navigate side or main branches within CTO, and also to decide on stunting strategy in such cases. To evaluate lesions distal to CTO, principally to avoid unnecessary stunting in negatively remodeled uh, lesions. Choose landing zones in diffuse disease and sub-intimal hematoma. IVUS helps a lot to reduce contrast volume in vulnerable patients with CTOs. IVUS is a great tool to complete procedure with low volume contrast. And to fine tune stunt expansion in subintimal space where uh, perforation is a very, very important thing, which the operator has to avoid. So sizing plays a crucial role, which can be done with IVUS. Thank you.